Thank you, Maulik, and thank you all of you for being here. So we heard the conversation that Chawla had with us about sensitizing us about the CKM syndrome, and I'm going to move ahead talking about revolutionizing the cardio-kidney metabolic care in type 2 diabetes with oral sema. So there are two stories that I'm going to be sharing with you. This is my financial disclosure, and I am contracted for this conversation. So the two cases or two stories that I'm going to talk about is one for type 2 diabetes with high risk CV factors, and then the second we move to talk about an individual who already has cardiac disease. So the first one is type 2 diabetes with existing risk factors. So we're talking about Anil, who has diabetes for last 6 years, 55-year-old with angina, currently on metformin and sitagliptin. That's actually 100 milligram a day. Telmisartan and rosuvastatin. BMI of 31, blood pressure 150/90, A1C at 8, LDL at 130. So things for us to improve there, and triglycerides at 170. So what are the clinical considerations that we have for Anil? A1C is above target. Showed the high BMI, so is obese, has dyslipidemia, has hypertension, and hence has high cardiovascular risk. I don't think there's any contention when you come across an individual with these comorbid factors. So when you look at the QRIS score for Anil, he has a risk of having a heart attack or stroke in next 10 years. It's high. It's pretty high at more than 30%. So can we just sit tight and ignore the risk that Anil has? Will it suffice for us to get his A1C from 8 to a 6.8 and be happy that we've taken care of Anil's risk ahead? Well, probably no. So how do we manage Anil's current state of high CV risk in the context of type 2 diabetes? So when you look at the ADA 2025 guidelines, and Chawla did share this with us, when you're talking about achievement and maintenance of both glycemic and weight goals. So one of the problems that we saw Anil had, besides high sugars, was the obesity or higher BMI, besides hypertension, dyslipidemia as well. And what the ADA 2025 is also saying, that your efficacy, when you look at for weight reduction and glucose lowering, so if you're looking at an agent which is going to be helping you, you are talking about GLP-1 with proven CV benefit as the first line therapy in patients with type 2 diabetes or with ASCVD or high CV risk. So either of those circumstances, whether you have existing ASCVD or you have the high risk factors, your GLP-1 becomes the first drug of choice there. So evidence supporting the use of oral sema in type 2 diabetes with high risk CV. What is the evidence? We are speaking and saying that yes, probably Anil needs to be looked at from that perspective. So when you look at the data for oral semaglutide and you look at its pioneer trials, which was the phase 3 program for oral semaglutide, and you look at a large proportion of patients achieving an A1C target of less than 7 with oral semaglutide. So when we talk about managing Anil and similar patients, we do have glycemic goal in mind, and then we are looking at the other factors also. So we are choosing a drug which has great efficacy. When you look at the data from Pioneer, 7 out of 10 patients achieved A1C target of less than 7. And not too many drugs are going to show you this, like 70% of the drugs in those trials achieving an A1C less than 7. 8 out of 10 achieved A1C target of less than 7 when initiated within 1 year of diagnosis of diabetes. And this is important. Very often our traditional approach has been that, lifestyle, look at metformin, why should we be so aggressive on drugs, let's give time, or maybe if we perceive that the drug may be expensive, then let's keep it for later. That's how our patients also perceive it, isn't it? When you give a drug which is expensive, they start talking, no, we don't want such a heavy drug. So there's nothing like a heavy drug. It's a drug which has benefits when given at the right time. And clearly data showing that giving it to somebody who has 15 years of diabetes, you're losing those precious years where you could have offered him or her the benefit. Also, when you look at the data and sub-analysis of patients in these trials who had a high A1C to begin with, oral sema actually provided an A1C reduction of up to 2.6% when the baseline A1C was more than 9%. And I always urge everyone in meetings that when you start looking at data for efficacy, always look at the baseline A1C. Most of the phase 3 trials that you'll see in the general population, the average A1C would be about 8.1, and which is where you get that typical reduction 0.67% by DPP4s, 1% by 0.9% by SGLT2 and so on. But you want to see the efficacy of a drug. It doesn't mean that it's going to cause only 0.9% or 1%. You look at the subset where you're starting high. And similarly here, if the subset of patients you're looking at with more than A1C of 9, you're seeing a 2.6% reduction, which is what we want. So 1 in 2 patients achieved also more than 5% weight loss. Now that's important. 1 in 5 patients achieved more than 10% weight loss. So it's not only a drug with great A1C reducing efficacy, but also more number of patients doing at least 5% weight loss. You also saw 1 in 2 patients which achieved the more number of patients achieving weight loss of more than 5% with oral semaglutide as compared to its competitors. So when you look at the Pioneer program, you had different drugs that it was compared with. It was compared with empagliflozin 25 milligram, liraglutide 1.8 milligram, sitagliptin 100 and so on. So against all these comparators, it did better on the weight front. So oral sema reduces body weight through appetite suppression. So energy intake and food consumption are reduced with oral semaglutide as compared to placebo in these trials. And they have data showing that when you look at the energy intake in these trials they studied, there was a 35% relative difference in energy intake on the sema group as compared to placebo. It also scored better on questions related to food cravings when patients were given a questionnaire in these trials as regards their food preferences, food craving, control eating and portion size. They clearly reported that those patients who were on oral semaglutide, they had lesser food cravings. It also reduced waist circumference, an independent predictor of atherosclerotic risk disease at the 26-week duration. So you're seeing 3.7 centimeters in the oral sema group versus 3 centimeters in the empagliflozin, 2.3 for oral as compared to oral sema as compared to 0.6 centimeter only in the sitagliptin group. And as an add-on to insulin, again, it's still, even when added on to insulin, it caused a 3.6 centimeter waist reduction. So other additional benefits of oral semaglutide. Anil also had dyslipidemia, and in spite of being on statins, the LDL was high. So are the drugs that we are choosing here, is it going to have additional benefits on lipids and blood pressure as well? Well, so we see the data for LDL cholesterol reduction, triglyceride reduction, total cholesterol reduction, and some improvement in HDL cholesterol in the oral semaglutide group. Also found to reduce systolic blood pressure and vascular inflammation. So we see a reduction of systolic blood pressure to the tune of 5 millimeters of mercury in the oral sema group. And you're also looking at HSCRP, which would be a standard marker for inflammation. The patients on oral sema did far better than the ones on empagliflozin in terms of inflammatory reduction. So what positive effects could Anil have noticed upon starting oral semaglutide? Well, the potential benefits: A1C was above target, patient was obese, dyslipidemic, hypertensive, and of course high cardiovascular risk. So up to 2.6% A1C reduction is what we can hope for Anil. More than 50% chance that he loses 5% or more of weight. 20% reduction in LDL cholesterol, up to 5 millimeter mercury reduction in systolic blood pressure, and 37% reduction in the inflammatory milieu. All these would definitely help Anil in the prevention of his high risk for either stroke or cardiovascular events. We then move to looking at another story for somebody who has type 2 diabetes with already established cardiovascular disease. Your first individual was one with risk factors, and we showed oral semaglutide may be a great option there, especially if used early on. But here you have John, who's 67, 10 years of diabetes, MI for 5 years, 5 years back had an MI on metformin and dapagliflozin. So fair, today many of us have been made aware that it should be metformin and dapagliflozin for somebody who has a cardiac pre-existing condition. Maybe after this Diabetes India and within a month's time you will see dapagliflozin disappearing from these examples, and you may see empagliflozin coming in all the examples. And I'm sure all of you have noticed the force on that. So this patient is on an SGLT2 on metformin, atorvastatin, ramipril and aspirin. BMI of 34, blood pressure 145/85, A1C of 8.5 and an eGFR at 65 ml per minute. So you're again looking at the problems that John has. Previous cardiovascular disease, had MI 5 years back, is obese, A1C much above target, Hypertensive, well, we can improve there also with the 145/85, and future risk of further cardiovascular events, which may sometime turn out to be even fatal for an individual like John. So what does the ESC say? The risk assessment for future CV events, patients with ASCVD or when you're looking at these patients, what do you want to offer them? And those who belong to having more than 20% scoring, there's extremely high risk for future events. So how do we manage John's CVD in the context of type 2 diabetes? GLP again are recommended for management of CVD in type 2 diabetes by the 2023 ESC guidelines. You're looking at presence of cardiovascular disease on the background of type 2 diabetes, and clearly when you're talking about type 2 diabetes along with ASCVD, your two drugs that get recommended are GLP-1 receptor agonists and or SGLT2 inhibitors. We talk about type 2 diabetes and heart failure, SGLT2 scored there and probably become more essential. You look at those with chronic kidney disease, and there again you will have some stronger evidence for SGLT2 and probably Finrenon. But when it comes to ASCVD, GLP-1 clearly become the choice there. So the recommendation for GLP-1 patients in chronic coronary syndrome is those GLP-1 receptor agonists with proven cardiovascular benefit are recommended in patients with type 2 and chronic coronary syndrome to reduce the cardiovascular events independent of baseline or target HbA1c and independent of other concomitant glucose lowering medications, which has a class 1 level A evidence for this statement. The other recommendation is GLP-1 RA should be considered in overweight, BMI more than 27. Here John had a BMI of 34, or obese chronic coronary syndrome patients without diabetes also to reduce CV mortality, MI or stroke. Again, a level 2A B evidence for that recommendation. So when we look at the evidence for the same, oral sema addressing multiple CV risk factors in type 2 diabetes. What did we see across the Pioneer program? A post-hoc analysis of this Pioneer 1 to Pioneer 8. HbA1c reduction of more than 1%. Body weight reduction of more than 5%, LDL reduction, systolic blood pressure reduction of more than 5 as we showed in the previous slides, and an increase or at least no worsening of eGFR was found across the Pioneer program. We specifically look at the Pioneer 6, which was the cardiovascular outcome trial, a subgroup analysis. What they found here was up to 49% MACE reduction in people with CV risk and no prior MI. And you look at a pooled analysis for Pioneer 6 and Sustain 6. Sustain 6 was the cardiovascular outcome trial for injectable semaglutide. 1.7 more life years free of new or recurrent MACE with semaglutide in people with type 2 diabetes and high cardiovascular risk. A 24% reduction in MACE in this pooled analysis, along with a 32% reduction in stroke, and which is what we want to offer the kind of protection to John. So transitioning from cardiovascular safety to cardiovascular benefits, very often this question comes up in terms of, Pioneer 6 for oral semaglutide showed non-inferiority and cardiovascular safety, did not show any superiority benefits for oral semaglutide. But Pioneer 6 was a trial which was designed to prove non-inferiority. They have another trial, the results are coming out next month, SOUL, which is finished, and we've been happy to be part of the investigator team for the SOUL global program. It was designed to prove superiority. Event and time-driven trial, up to 5 years, 14% significant reduction in 3-point MACE. So the top line results were announced some time back, and it has shown 14% significant reduction in 3-point MACE. We await the final details of the SOUL trial. So despite modern evidence-based therapies, there is residual cardiovascular risk. Now that's important. We may sometimes feel, oh, we already used an SGLT2 inhibitor, or we have used a statin and we've used aspirin. Is that good enough? But today evidence is showing that despite all of that, very often there is residual cardiovascular risk, and hence to an individual like John, who had MI 5 years back and has a probability of landing up with another event, you need to offer much more, which is where GLP-1 receptor analogs very often, along with SGLT2 inhibitors, will cover that gap and offer that extra metabolic, renal, and cardiovascular protection that's required for John. There's also some data about reduced incidence of cardiovascular events with this combination therapy. Very interesting study. The patients who had an MI and then put on different set of drugs, they followed them up and found that in this 26-month follow-up period, those who were on both GLP-1 and SGLT2 had far lesser chances of recurring events as compared to those who are either on SGLT2 or GLP. So we start thinking of this combination, and these would be the potential benefits for John. Up to 1.5% A1C reduction, up to 5 kg weight reduction, 5 millimeters mercury reduction in systolic blood pressure, 14% 3-point MACE with the sole applying results, and 1.7 years CVD free life years. So individuals like John, probably we need to think of reducing the residual risk which remains for him. Thank you. Thank you so much.